Insulin prices have been a growing concern for Americans. How have PBM practices such as rebate negotiations, formulary placements impacted the affordability of insulin for patients with diabetes?
Thank you for that question. Actually, the net price of insulin has actually decreased from 2007. We're actually lower today in terms of the net price of insulin than we were in 2007. But most patients haven't necessarily felt that, again, because PBMs insist on charging patients a full list price of the medicine, not the negotiated rate. The typical insulin has a rebate of about 84%. 84% lower than what many patients are being asked to pay. So our companies have come forward. They've offered lower price versions of insulin in the hopes that those lower price versions would actually get covered on formularies, and typically they've been rebuffed. The PBMs have not had an interest in putting lower price insulins on the market. All three of the insulin manufacturers earlier this year came forward, and starting January of 2024, all are offering insulin to patients, be it commercially insured or uninsured, for $35 a month as a way to circumvent the current system, again, where patients are often overcharged for medicines like insulin and made to pay the full undiscounted price when they go to the pharmacy counter.
Mr. Scott, how would you respond to that?
I would say a couple of things on insulin and then on the negotiation process. On insulin, as Lori noted, drug companies did happily lower the list price on a number of those products, and my understanding is that there is access being provided to those through the PBM formularies. But essentially what we're conflating here is not only did the list price come down, but did the net cost come down to the same low discount level? Because the PBM's job, when the PBM's negotiating with the drug company, is to try and get the competitors to each offer the discount, and whoever's going to take that net cost to the lowest point, that typically is what gets the formulary placement if all the clinical considerations are equivalent. And a number of PBMs, I would also point out, have, even prior to those companies lowering their list prices, put programs in place to cap or limit out-of-pocket costs for insulin specifically to patients on plans. If I could, Congressman, just to respond to the earlier questions that you asked some of the other panelists, I talked a little bit now about how we negotiate with pharma, and there's also a separate negotiation with the pharmacy. And Mr. Chancey makes a good point that oftentimes 83% of independent pharmacies are part of pharmacy services administrative organizations that collectively bargain on behalf of thousands of pharmacies together with the PBM to help them negotiate favorable contract terms. So I think that's a good point to highlight.
The final question for Mr. Burton. How can Congress ensure that PBMs prioritize the inclusion of biosimilars in formularies and promote their use to reduce health care costs?
So I think there are a number of opportunities. The simplest that we've encouraged, that Representatives Custer, Miller Meeks, and others have introduced, would real simply require in Medicare that Medicare plans prefer new generics and biosimilars when their price is less than the brand price. This still gives PBMs the opportunity to negotiate for a lower price. It still allows brands to exclude generics and biosimilars from the formulary. They just have to do so based on by lowering their price. Because I think what's getting lost in this discussion of lowest net is lowest net cost to whom? There's a lot of discussion of lowest net, but that's to the PBM, to the plan sponsor. That's not benefiting the patient. And I think we have to get this back to what gets the lowest cost medicine to the patient.